Unrecognized mental illnesses lead to divorces, school failure, job failure, addiction, homelessness, incarceration. It is not their fault. Don't blame your primary care doctor for this. They've not been trained.
When a person has a psychotic illness, it's a puzzle for the entire community. They might have this illness, and the first responder might be a pastor in a church, it might be a high school teacher, it might be a college professor. Our effort is to educate everyone in the community and to activate them as a network of people.
Study after study confirms that early detection of serious mental illness makes a huge difference in recovery. So why don't we catch it earlier? Our guests on this episode explore the problem and provide solutions. Welcome to our podcast, Schizophrenia, Three Moms in the Trenches. From the place where schizophrenia and real life collide. East Coast, West Coast, Middle America. With Miriam Feldman, Mindy Greiling, and Randy Kay. We're very excited about this episode of Schizophrenia, Three Moms in the Trenches. If you're new to the podcast, welcome. Who we are is pretty much in the title. We are three moms. We each have a son with schizophrenia in various stages of recovery. We've written books about it, and this is our 112th episode of this podcast. And I want to thank you so much for your support and for listening or watching on YouTube and for being with us on this journey. Throughout so much of what we've been through with our loved ones, as many of you may feel, is that early detection, catching this brain illness early, can make a huge difference in recovery. It's a theme that sort of runs through everything. So in a moment, we're going to bring in, we have two guests this evening. One is Dr. Robert Smith, who's written a book called, it's all in the title, Has Medicine Lost Its Mind? Why Our Mental Health System is Failing Us and What Should Be Done to Cure. And he's going to talk about the value of early diagnosis. Then we're going to bring Vinod Srihari, who runs a program in Connecticut that I just learned about called STEP, and they are stepping up to the plate to do something about this. And so this is very exciting. I'm Randy Kay here with Mindy Greiling and Mimi Feldman. So how are you guys? Mindy, what's new?
I am on top of the world. As you know, as our listeners know, we've been trying to get Jim into supportive housing for a long time. And last summer, we finally got an interview, and then he had a reaction to one of his meds and couldn't even walk and hardly talk when we were there. So we got postponed until last week. And we went last Thursday, filled out all the paperwork, had an interview, had a tour of the building, which we couldn't do before because Jim was not able to walk unless he was pushing a cart, which wasn't really very safe. And now we still have to have the final bow tied with our paperwork approved. And Jim has to have a background check. And as we know, his background check isn't perfect. But I think they said they're looking for people that set fires or harm other people. And he hasn't thankfully done those things. So we're all but there. And so I'm on top of the world this week. You never know about next week.
Well, this is true. I hope Jim is on top of the world too. Is he looking forward to it?
Jim is so excited, and he's Googling, what is around this place. He's planning, where he will put his furniture. That is, I think, the most exciting part is that he's excited about it. And I should say one other thing. We had our program that people may have watched, and the financing last summer meant he would have a lot less money left over once he paid for this program, but they've changed the financing program. And so now he will basically have the same amount of money he has now because they've changed the program. So somewhere along the line, we can maybe talk about that. But the moral of the story for us and for our listeners is no matter what you learn, you have to keep learning.
Yeah, absolutely true. And I don't know when you, dear listener, are listening to this podcast as we speak. This day is February 4th, 2025. I guess I should say that, although it's always in the show notes. And things are a little bit in flux with our government, not going to lie. So we never know what funding is, what funding isn't. But right now, we just got to deal with the here and now and what it is. And for our listeners, your son Jim is how old?
Jim is 47 now, so I say never give up hope. Things get better over time. There's still the ebb and flow, but you're making progress usually the older you get, unless there's some tragedy like COVID that knocks you off your meds or something.
Right, I know that well. Thank you so much. Mimi, how are you?
I'm fine. Just running into some issues with Nick and his meds, and now all of a sudden the REMS have put a hold on his clozapine, and I don't understand why. And so just doing a lot of scrambling.
Mimi, do you have a supply of?
Yeah, I do.
You do. Yeah, good.
I do. So I don't have to freak out on that level. Though I do have a bag of Nick's meds. This is meds, guys.
Wow.
Yeah.
I have to sort through and figure out and get everything set up because I'm leaving town tomorrow and I have to leave everything in order. And Nick's good caregiver that he's been so happy with this last year is out now and may not be coming back. So I've got a different caregiver coming every day. So things are not being handled too efficiently right now.
The good caregivers mean all the difference.
Everything. It's just, and then you get a good one and then I sort of start slacking off and leaning on the caregiver and counting on the caregiver. And then you wake up one morning, the caregiver's gone. And so
parents are always the bottom line. And that's why we're trying to get Jim settled because, Roger's 80 and I will be 77 in 2 or 3 weeks.
Oh my God.
So we got to we can't be the bottom line after we're dead.
No.
Yes. And, in case you're wondering, we do have episodes about all of these issues, clozapine and the REMS required to take them. So please just check our list of episodes. And if you're new to us, you've got 111 other episodes other than this. So pick and choose the topics that are really helpful to you and topics about Clozaril. We have stories from other people who are on different medications, long-acting injections that are helping them. And so we try to be here for you. With that said, I do want to mention, and thank you so much for your fan mail. There is a way to write to us through our podcasting host, which is Buzzsprout. Unfortunately, we can't answer you on that platform yet, but those of you who have been listening know this, and I put a note. If you put your email address, I will get back to you, or one of us will get back to you. But please know that we are 3 moms, and legislator and an artist and a broadcaster. We have many jobs, but we are not doctors. We're going to have one on in a minute. We're not doctors. We're not social workers. Thank God for the social workers. We are moms and we're volunteer moms. And if you're calling to ask us for advice, we're not qualified to give you that. What we can do is steer you toward an episode that has the information that you need. We are here to educate and help you not feel alone, which so many of you have said we've done, so we're doing. So thank you for that. But we can't advise you in your situation as to what meds he should take or, what to do. We're going to do our best. And I promise I'll write back if you give me your information and give you empathy. But legally, we can't prescribe stuff and all that. So, but thank you for writing. We really appreciate it. My quick update is, unfortunately, I've been trying to get assisted outpatient treatment passed in Connecticut. It didn't make it past committee, I'm sad to say. They said there was going to be too much pushback. We're going to try again next year. My son is currently safe for the moment. He is in a program that is a transitional program and refusing to take medication. But he is agreeing to be drug tested. So we count our blessings and we keep our fingers crossed. And
that's really a step in the right direction.
For today.
Yeah, I know. That's what it always is.
For today. There's a song in Avenue Q that's like that. For today. I get all my therapy from Broadway musicals. Okay. So that's our update. My son's 42. Nick is how old, Mimi?
39.
39. So we've all been at this a while, and this is why I want to bring in our first guest, Dr. Robert Smith. We have permission to call him Bob. And Bob is a seasoned physician and thought leader, and he's sounding the alarm. Woo! We're going to sound it with you that medical doctors need fundamental training in mental health care. So welcome, Bob.
Yeah, thank you. I'm honored. I love all the three of you, your energy and your positivity of this critical.
Thank you so much. So I'm excited about your book. I've read about it. I read the synopsis and I skimmed it, not going to lie, but I did speak to you at length on Zoom. So if you're on YouTube, Mindy's holding it up. It's called Has Medicine Lost Its Mind? Raise your hand if you've wondered that yourself on occasion. All our hands are up. Because what it does, I've never seen a book like that. It exposes the problem of many mental health practitioners not having, let's just say, enough education in mental health care, but you lay out a roadmap for reforming the system. So why don't you tell us,
Sure.
about this book, about what you found, why is early detection important? Go ahead.
Sure. Well, I've been in this business since 1978, and I and many others have been working to get mental health care improved in the U.S. Medicine is not doing much about it. And so I decided to go to the public. That's the reason I wrote this book. Your listeners and viewers are apt to be a little upset about what I'm going to tell you right now. Everybody knows there's a mental health crisis. What people don't know is why it's happening. Simply put, primary care doctors are providing care for 75% of all mental health patients in the US. But they haven't been trained for this job. And the result is predictable. They overlook the vast majority of diagnoses altogether. The few they make and proffer treatment, it is ineffective. The downside of this is absolutely devastating. Unrecognized mental illnesses, depression, anxiety, addiction, serious mental illness. Unrecognized problems like this lead to divorces, school failure, job failure, addiction, homelessness, incarceration. And it is not their fault. Don't blame your primary care doctor for this. They've not been trained. In fact, if you talk to any of them, I've been always talking to them. One the other day told me, said, Bob, there's no psychiatrist in my town. Another one says, there's 2 or 3 psychiatrists, but it takes 9 months to get in to see one of them. And the point I'm making here with these examples is that psychiatry sees no more than 12% of all mental health patients in the US. Psychology sees probably another 12%. That means 75% are being left to untrained primary care doctors. And the solution to this is fairly straightforward. Train the doctors who are providing the care. But medicine has resisted this. And this is why the public needs to become informed and inflamed and start taking charge and doing something about it. And we can perhaps talk about that, and it's detailed in the book.
One thing I really liked about maybe the first third of your book, you go through why this is the case. And I'm just going to cite what I thought was the most graphic example in your book. And that was in the 16th century, the Catholic Church dictated that dissections where medical students were learning about the body, first, the head had to be sawed off because that was they wanted to take that head and put it in the church or wherever they were dealing with that sort of thing. And then the body was what was dissected, but they weren't even looking at the things in the brain that we now know show the progression of schizophrenia and other diseases. So I thought that was really interesting. And then you mentioned that the training of doctors hasn't really been updated for 120 years. And so I'm wondering, what kind of steps have you taken? You said there's resistance. What have you done? And is there any kind of a growing movement? And do you think your book will be a catalyst for just simply changing the education? You showed how there isn't hardly any. You had the charts of what they actually get each year, the students.
Sure. Well, let me make it explicit about training. And you're right, it hasn't changed in 100 years as far as mental health is concerned. Medicine, this is now over 4 years of medical school, 3 to 5 to 6 years of residency, provides no more than 2% of all of that time in mental health training. Now, this is in spite of the fact that mental health problems are the most common health problem in the US. They're more common than heart disease and cancer combined. There's some 1/4 of all people in the country will have a mental disorder. It's sometime in the next year, 1/2 over a lifetime. So it's incredibly common. And what's medicine doing? It's not training its graduates to care for the most common problem they'll see. This is where the title of the book comes from. Has medicine lost its blooming mind? And so, and this relates in particular, this isn't just garden variety depression or anxiety or drug abuse. This relates to serious mental illness. As you all know, I'm sure better than I do. Again, I'm a primary care doc, internal medicine. But I've had psychiatry training and so on, but I'm not expert in psychiatry. But there is a 2 to 5 year prodromal period before people actually become schizophrenic. This happens in at least 3/4, if not more, of all patients. Now, in this prodromal period, people are not accessing psychiatrists at all. Now, for serious mental illness, once diagnosed, does require a psychiatrist. Primary care people can't manage that primarily. But where they play a key role, if they were trained, is in spotting problems early. The kid or the woman who suddenly loses interest in school, who starts becoming depressed, withdrawn, all of these are warning signs that something is wrong. Minor psychotic episodes, lack of interest in things, difficult relationships, all of these are warnings. Now, the doctor would need to spot the problem and simply be aware this is possibly prodromal schizophrenia, and then make proper referral. They won't take care of it. But right now, they don't even have a chance of recognizing it. Most of them don't even know there is a prodromal period to schizophrenia.
Wow.
And so these are critical issues all across the board. It isn't just minor mental illness, if you can say that, but it's serious mental illness also. And in serious mental illness, I'm sure you know better than I, but the mortality rate is much higher. Many people with serious mental illnesses are dying 15 and 20 years younger than other people.
And not living such great lives until then. Mimi, you look like you want to say something.
Yes, I have a question, because we hear this, and I've been hearing this for many, many years, these red flag signs, loss of interest in school, grades dropping, friends.
Sure.
But the thing that I always say is, if you were to make a list of red flags for mental illness and normal teenage behavior, you'd have the same list. They're oppositional, they're confused, they're angry, they don't know what they're doing. they're impulsive, all these things. And I know that's what I went through with my son. It's like, well, this is how teenagers just are. So my question to you is, as a doctor, if you identify these symptoms, if you will, that can be found during that prodromal stage, can you assign a probable diagnosis of schizophrenia to it and do any kind of mitigation or treatment that's going to make it any better? Because you see, I think back to my experience, and believe me, every night of my life I lie in bed and I think about what could I have done different, what didn't I
Yeah.
see? But even if I had known all that, then what would they have done when Nick was 17 and showing all these signs, but kind of just
Yeah.
like a regular teenager does?
Sure. And that's a problem. And now throw into that untrained primary care doctors who will simply think it's probably just a teenage problem. In fact, there are things that can be done. Many of these people become depressed. It can be treated. But the critical thing, or minor psychotic issues, this would worry me about some incipient problem. But the critical thing is recognizing if any kid starts failing in school where they've been doing fine before, of course you look at drugs, but also incipient prodromal schizophrenia. And it's simply getting it on the table. It has been shown that the sooner the diagnosis is made, the shorter this prodromal period is, the better the response to treatment once they become schizophrenic, and the better the follow-up is, and the shorter the subsequent episodes are. And so I agree with you. And I, having raised 3 kids, I know what you're talking about. But it has to be on the radar. Right now, these people are coming in. I used to work on the inpatient service, supervise it at Michigan State. And we would see psychotic or schizophrenic, overtly schizophrenic people coming in there to make a first diagnosis. And when you go back into their history, this has been going on for 3, 4, 5 years. Problems, they all of a sudden start falling off the cliff. And I can't answer your question, how you're actually going to diagnose it. But I do think it does some good in getting attention and perhaps getting them into the psychiatry system early.
Well, one thing that
Really-
comes to mind for me is that one thing is, if back then somebody had said to me in no uncertain terms, this could be schizophrenia, keep him away from marijuana at all costs, that would have made a huge difference.
Yeah,
Because
Exactly.
we didn't know.
exactly. Mindy, and then I have a question for Bob, and then we're going to bring in Vinod.
Okay. When Jim actually himself made an appointment, went to our primary doctor when he was in college and having these symptoms. And the doctor did say that he thought Jim had depression and prescribed an antipsychotic. I liked your answer better, where you said you would refer to a psychiatrist, because by getting that, it was a very strong antidepressant, we found out. And by getting that and adding to it his prodromal schizophrenia, which we didn't know about at the time, it just set him on fire. He went manic just like that, and punched holes in our walls, and we had all sorts of issues and had to call the police. And if he'd been referred and maybe gotten a softer antidepressant, or not so much, or somebody who knew a little more about it, then that might not have happened. But so I liked your answer, to refer. I think that's a good practice for all specialists. The primary should refer the minute that he or she gets in the deep end. My question then is, though, what about nurse practitioners? You can't get in to see a psychiatrist. There don't seem to be even enough general practitioners anymore. And so often when I go to the doctor, I end up with a nurse practitioner if I need to go in and I can't get my regular doctor. Are they trained any better than general practitioners?
Not really. There are so-called psychiatric nurse practitioners who are extraordinarily well trained, and if you have access to them, that's ideal. But nursing trains a bit more in the so-called biopsychosocial model and in mental health things, but they are not trained to diagnose and manage even garden variety depression, much less serious mental illness, and recognize it any more than medical people are. And so I don't think you can be comfortable in thinking that nurse practitioners or physician assistants or primary care doctors, any of them are going to be much better at recognizing and treating mental disorders, or in the case of serious mental illness, recognizing them quickly and referring them quickly to psychiatry. I
Well,
should
their
point
their
out,
training hasn't been updated either then. That's discouraging. Well, whatever we can do to help promote, when you get some kind of movement that I would love to plug into it as in my state and get people on it to update that education. Sounds
can I
very
just point
important.
out one thing quickly is I'm not advocating that every doctor that goes out in primary care become a psychiatrist. They
Right.
simply need to be as competent with mental health problems as they are with medical problems. Psychiatry and psychology still have a big role, but I think it will largely be in a referral from a skilled primary care doctor.
Thank
Excellent.
you. Yeah, I love what you say, put it on the table, because I will echo what Mindy and Mimi were saying as a mom, is that no one, first of all, I did not educate myself about schizophrenia. When you have a baby, you're like, you don't go, oh, let me educate myself about schizophrenia. You know, you're doing diapers and you're doing all those pediatrician things. If you've never had schizophrenia in your family, Mindy, I know you did with your grandmother, but if you've never had it, you don't think to educate yourself. And when my son was going through the prodromal stages, if someone had said to me, you know, just in case, let's put this on the table.
Yeah.
You know, then I would, and because who's on the front lines? We are. And if they had said, this is, you know, here's a pamphlet. This is what you need to look out for. You know, I'm going to give you a name of a doctor just in case, just to get it out there so that when the families see what the signs are, or even if it gets to the case of first psychosis, which we're going to bring in another guest to talk about in a minute, that would help us. And I will mention this, I don't know the exact title of the book, but I'll put it in the show notes. With what you said, Mimi, about marijuana, there's a book called, I think it's called 10 to 25. It's about, and they're considering adolescents now starting at 10 in this particular book, about the brains of adolescents and how to reach them. And basically, in this book, he speaks about, it's not so much getting the mom to talk to the kid about marijuana. It might be the nurse practitioner or the doctor saying, hey, you might have this thing. If you have this thing, here's what you need to look out for, and putting the responsibility on the adolescent is something that I'm not sure about mental illness, but I know with diabetes, they've had studies that show if you tell the kid, hey, you can't do this, it's much more effective than telling the mom to tell the kid what they can't do, because we're all moms and we know how that goes. So, Bob, just real quickly, and you know, you're not leaving us, you're just kind of going in the background for a minute while we talk to Vinod, but do you feel that medical schools don't properly have this in their curriculum? Is this part of your roadmap for reform?
Yeah, serious mental illness is as ignored for medical students and residents as much as lesser degrees of still difficult mental illnesses, depression, anxiety, drug abuse. Those are kind of the common mental health problems you see in primary care. But none of this is addressed. There is only supervised training students and residents get is an average of 5.1 weeks in the third year of medical school on a psychiatry rotation, where they might see somebody with schizophrenia or psychosis and have some attention to it. But idea of supervised care has not covered mental health, particularly serious mental illnesses, throughout the entire rest of 7 years or so of training. And so they get a smattering of it there, but it's long gone by the time they end up in practice. It's simply 2% of training time is all that goes. Medicine supervises training to who laid the rail of heart attacks, cancer, strokes, emphysema, name it, everything. They don't do that with mental illnesses, even though they're the most common health condition in the US.
Wow, that is eye-opening. Thank you so much, and I'm so glad you wrote this book. Again, the title, Has Medicine Lost Its Mind? Why Our Mental Health System is Failing Us and What Should Be Done to Cure. You have a roadmap in that book. With that in mind, I'm going to bring in Vinod Srihari, and I've just met Vinod, but I did speak to someone who works with him named Nina. And I was in a mental health committee meeting, and she spoke about this program in New Haven, and it's called STEP. And the only thing I'll say, and I'm going to let you explain it, Vinod, is that it's a clinic staffed by mental health providers, but it's not just about doctors. Other people can be educated early for these early signs for early treatment, like social workers and nurses and school psychologists. So, Vinod, tell us about STEP and tell us what your mission is and what's going on.
Sure. Yeah, and thank you for having me on. So STEP is the Specialized Treatment Early in Psychosis program, and it's based at the Connecticut Mental Health Center in New Haven. And we started as a clinic in 2006, and we were really implementing something that had been shown in other countries around the world, which is if you organize care for people who are early in the course of schizophrenia, using a specialized team that is oriented towards young people and towards new families who've not interacted with the mental health care system before. And you provide what are already available and established treatments that are based on empirical evidence, medication, psychotherapy, assistance with going back to school or college, assistance with finding work. So interventions that are not novel in the sense that they aren't experimental, but have already been shown to work. But if you pay some attention to packaging it together with a team that's oriented to young people, you're much more likely to engage them into care and to keep them in care and to get better outcomes in terms of functioning, avoiding relapses, getting back to school and work. So about 30 years ago, there was a series of articles and some innovative programs in Australia, Canada, the UK, Northern Europe, that had shown that this was possible to do and that it was cost effective. And so we implemented this program in 2006 based on some of that information and completed a randomized trial with NIH funding, showing that you could run this program within a publicly funded community mental health center and improve outcomes compared to usual care in the community. So that was the sort of the first iteration of STEP. And since addressing that issue of quality of care, we did another study that was funded by the NIH to try to reduce access delays, which is a different kind of challenge. It involves having the clinic engage with the community around, because as you all know, pathways to care after a psychotic episode can be quite prolonged and tortuous and confusing. And so we ran a campaign for 4 years in the greater New Haven area to demonstrate that we could shorten this delay from psychosis onset to treatment. It's called the duration of untreated psychosis. And we did it in a controlled way. We had a site in Boston that provided very similar treatment, but did not mount this public awareness campaign, because we were trying to demonstrate to ourselves and others that any reductions we saw in delay were because of what we were doing in the community to campaign to shorten the delay. and were not just related to accidental factors that happen to change over the course of time. So this campaign, which we branded as Mind Map, used a combination of media messaging, social media, mass media, to try to find people who had not yet tried to seek help. These might have been individuals or families who didn't even know that they were confronting psychosis. They might have been confused about what it was. So there was a lot of educational messages we put out into media. The other part of our campaign was to target providers. So these are individuals who might have identified psychosis, but we all know that from that point to getting someone into ongoing care is another journey. And so we wanted to make it very easy for providers in our region to send individuals to us. And the third part of our campaign was reducing wait times at our front door, by which I mean we never had a wait list. We still don't, but between the time a young individual agrees to come to care and when they actually show up for care, many weeks or months can elapse. And so we had a quality improvement approach to drive that down to less than a week. And we now average at less than 3 days. So the idea being that people are very ambivalent about getting care, especially if they've never been in treatment before. And the best way to cut through that ambivalence is to bring the person into the clinic to see what care is like, which tends to be an anticlimax. It's just people talking to you. But
Can
young
I
people
just
often have,
could I just, excuse me, I am just blown away that you have never had a waiting list and you still don't. We have a first episode program in Minnesota with, I know you work with Yale and we work with the University of Minnesota and NAMI and a hospital, and it started after yours. Maybe we copied what you're doing, but it's a wonderful program. But there's always a waiting list, and people beg to get in, and they can't get in, or they don't know about it. And so you have this wonderful outreach campaign where they know about it and they can get in. Where do you get the funding that you don't have a waiting list?
Yeah, no, it's a great question, and I think in every system and setting and state there are different kinds of challenges. So the center in which the clinic was built is a public academic collaboration between Connecticut's Department of Mental Health and Addiction Services and Yale's Department of Psychiatry. So the operational funds come from the state, and all the leadership and staff are from the university. And when we built the clinic, it was very important to us that we not have delays related to insurance status, which in our state and in many others, ironically, having commercial insurance often leads to delays because there's a lot of confusion about where you can go for care. So our public center, which traditionally serves people with Medicaid, Medicare, or no insurance, agreed to take individuals with commercial insurance as well. So we have since 2006 taken people without regard to what their insurance status is. And they were provided 2 years of care. So here's the catch, I guess, Mindy, which is we still provide a limited number of years of care. It's now 3 years of care. And before that time elapses, we graduate individuals to routine care in the community so that we can keep our front door open. So that's the way we manage flow, is we provide early intervention, but we also move people along so we can keep slots open for people coming in. So we've managed to run without having a wait list since 2006.
We move people along too. We move people along as well, but still we have a wait list. So congratulations.
My understanding, Vinod, is also that, see, part of this is the awareness and the willingness of a young person. And when you say young, define young, what's the population you treat?
16 to 35.
16 to 35. So that's a wide range. It's almost 20 years of early psychosis treatment. Isn't there a number they can call? Like, I remember Nina saying something about a number that if they call for help, you'll help them. Is there, if somebody's, how do you get people in? Is it referrals? And I want to also know more about your campaign to to educate everybody about early signs so that you can get these referrals?
So I just put the background that our marketing team would have wanted me to have, but so the campaign is called Mind Map. So if you Google Mind Map or you Google STEP Yale, you'll find all the information on our website. And there is a single number that anyone can call from around the state. It's 203-200-0140. And if you can't remember the number, Mind Map or STEP or psychosis and Yale are terms that will help you find our websites. This campaign, Mind Map, we tested for 4 years between 2015 and 2019. And we targeted just 10 towns in the New Haven area because we calculated that that's the capacity we'd be able to absorb in our clinic. And we were able to half the delay from about 10 months to about 5 months over the course of those 4 years of campaigning. And that's the campaign that we're now scaling up across the state, where we've partnered essentially with all the local mental health agencies. So this is the publicly funded mental health system that's, I like to think of it as like the skeleton of public mental health services in the state, who have all agreed to take individuals that we send to them, that we screen when they call this number and determine that they're likely early in the course of a schizophrenia spectrum disorder. We do this on the phone or on Zoom within 24 hours. And then we refer them to this network of 20 clinics that have all accepted to take them, again, without regard to insurance status and with no wait lists. And we're 1 year into now this statewide effort to scale up rapid access to care. And we are going to follow outcomes for everyone. So our goal is to, over time, provide workforce development to all the clinics that need them, and to share lessons across this network. So clinics that are doing better on hospitalization outcomes or vocational functioning can share their lessons with clinics that are not doing so well in terms of the outcomes of the populations they're treating. So we've built a statewide learning health system, which is collecting data on outcomes and aims to use that to improve performance over time. So that's the goal.
Thank you. So interesting. And I'm hoping that this is a model that I know you've just spread it out across the state. So as you gather more data, it might help other states as well. Can you speak to the value of early education for many providers into the signs of mental health? And Bob, you can turn your microphone on as well. So what you're doing, how does that relate to what Bob is talking about with people being more educated?
Yeah, I know Bob spoke about this eloquently. I agree with everything he said. I guess what I'll add there is, primary care is absolutely a vital part of this network of care that we conceive, in the state. So when a person has a psychotic illness, it's a puzzle for the entire community. They might have this illness, and the first responder might be a pastor in a church. It might be a high school teacher. It might be a college professor. But they almost always, in the year prior to coming to us, have seen either a pediatrician or an internist or required vaccinations for school for some reason. There has been contact. So it is a challenge, though, given the busy workflows in primary care, to have providers screen for mental illnesses. So our campaign doesn't rely on any one of these nodes. Our effort is to educate everyone in the community and to activate them as a network of people. So I would say most people want to know how to help. When they see something wrong, they often are not empowered to know what to do. And our goal is to give them a simple call to action, a telephone number. We take calls from anyone, any of those people, any agencies, bystanders, police, to try to help figure out how we can get that young individual into care in as comfortable a way as possible. And of course, that isn't always the way it usually goes. There are sometimes unwelcome interactions with the police, with emergency rooms. But we've been reaching out to police departments in the state, and some of them are incredible leaders in their community who are very open to the notion of serving as a conduit to care rather than to jail, when they can. So our message for identifying signs and symptoms is going to every stakeholder group, not just primary care. And it's in part an acknowledgement of what Bob has already talked about. Is it's been very difficult to get primary care to function as a kind of referral node for reasons I think that have to do with partly what Bob said, training, but also just time and all the different tasks they have to do. And I would add too that young people having these illnesses, as you all know, sometimes have reasons not to want to divulge what's on their mind. And so they might arrive at a very receptive clinic, but not want to talk about symptoms they're having for fear of being strapped down and sent to the ER or shocked. So I think some of the fantasies they have about mental health care get in the way of their willingness to tell even an attentive clinician what's happening. And mental health systems have not been very good at marketing our services either. And so some of our efforts are to try to use marketing actually in a very deliberate way to advertise what we do in our clinics that could help them, which might mean help finding a job, help going back to school. You don't have to take medications to come to our clinic, for example. And our intent is not to send you to the hospital and lock you up against your will, even though, as you all know, sometimes that's necessary. Our in the main, we're talking most of the time. Yeah.
I have a
There are
question
five
for
of us
both
here,
of you.
so yes, I was just going to say it's good to raise our hands now, and I'll call
okay.
on you. So
Okay,
go ahead. Mindy, you go ahead.
Okay, I have a question for both of you. Randy mentioned anosognosia, and you were saying, Vinod, about maybe the young person doesn't want to talk about what's going on, or they have preconceived notions about the mental health system. What if they have anosognosia? And that means they don't really believe, their brain does not allow them to know that they have mental illness. And so no matter what you do, they're going to maybe think it's scary, or they're maybe going to think it's fine for somebody else, but they themselves do not have any mental illness. So there's no need for them to participate. What if Mimi showed up with Nick? She somehow saw your outreach and got him to go, but then he said, heck no, I am not going to participate, and went home. Can Mimi participate? Can she, what do you do about people with anosognosia? Because that's the biggest reason people don't get treated.
Yeah. So I've been working with individuals with psychotic illnesses for more than 25 years now. And I will say something that I think would sound strange to people who have not been with a person with schizophrenia or treated them, which is much of the time we learn to work with people effectively, even though they don't agree that they have an illness. And I think it's something that seasoned clinicians do all the time. And I think it's a mix of offering something that the person does find attractive. So like I mentioned, there are some individuals who come to our clinic because we help them find ways to get back to school or work to meet some personal goal that was interrupted when they became ill. Admittedly, some initially come in because their mothers twist their arms and bring them in. We
Hey,
never
moms.
make acknowledging that one is ill or having insight a requirement for being in care, because if we did, that would just be a recipe for prolonging the duration of untreated illness. So while I agree this is a real challenge, and in terms of a public campaign, we are often campaigning to people around the person because the person themselves, once they've had a psychotic illness, may be not as receptive to the message that this is something that requires professional care. So I'll say it is a challenge, but I found that we're very happy with many individuals who have an excellent course of treatment. But if we had to sit them down and argue with them about what it is they had, we would not be on the same page. And that's a win for me. I'm willing to live with that. But you're absolutely right. This remains a challenge, and especially with individuals we find early in the course who often respond very well to treatment, they will often stop treatment because they responded so well, and they don't see evidence of needing to continue medications. So it's a yeah. I don't know. I will add one more thing in relation to what Bob mentioned. We have done some. We have some evidence to show that people who are in the prodromal phase, that is before they've had a frank psychotic episode, often have much better awareness that they might be ill and are more willing to seek out care themselves, versus once they've had a frank psychotic illness, we're often relying on their mothers to bring them in. So, there is an opportunity with earlier detection to bring someone into care before they've had an episode that might bring them into conflict with their neighbors, with the police. So in some ways, that is the next phase of progress, is identifying people before in a way that welcomes them into care, that doesn't label them with a concern that they may not welcome at that point.
Thank you. Bob, anything to add to that? Thoughts?
Well, Vinod has expressed it nicely, but the critical thing, I think, would be establishing a good relationship. And I think Vinod has expressed that already so nicely, but in getting someone into treatment of any sort, often when they don't agree that there's a problem, you first have to establish a strong doctor-patient relationship. And that may not occur at the first visit. It may occur over weeks to months, but it requires that. And even then, and I think as Vinod was alluding to, you can get them into treatment and seeing you and accepting that they don't think that they have a problem. I don't think you have to convince them to articulate that they are schizophrenic to be effective in treatment, but I would certainly defer to Vinod on that.
No, I totally agree. Thank you for bringing that up, Bob. I think the building an alliance is so key. Having said that, as providers, we have to work hard at that. I think as mothers, you're actually living with a person who's often refusing care. So it's I think you're dealing with something far more complex than we are, and sometimes it's helpful to have a clinician who's not in that fight, because unlike you all, we can get fired. And so I often explain to family members that while I agree with them that it's frustrating to have a person being unwilling to come for care, we have to rely on our marketing skills, so to speak, because we could get fired at any moment. And even with assisted outpatient treatment, it's tricky to maintain a treatment relationship without some kind of mutual shared alliance, even if it's not based on an awareness that one is ill.
That's quite true. And we're down to our last 5 minutes, and I keep thinking of this story that might illustrate it. One of the most, I've heard you both say very powerful things, but one thing that's really hitting home for me is that if you can catch them before that first psychotic episode, before it, and that's when you get the diagnosis, because it's this much from column A and this much from column B in the DSM. I get that. But I remember my son, he must have been about, before he dropped out of school, so 15 maybe, so prodromal, but not yet psychotic. And I remember I was having a tough time with him in that, tough adolescence phase. But he was in his room looking through photographs, and there were photographs of him with his best friends in youth group who he hadn't spoken to in a while because he was getting very isolated and writing poetry and thinking that everything's a government plot. And I remember he sat in his room and he just looked at the pictures and he started crying, and he said, "Mom, I used to be so happy. Why aren't I happy anymore? I'm going to go take a walk and figure it out." because he thought he could figure it out by himself. But that is the moment, if I had known, or if someone at school had been able to say to me, or if a rabbi or a pastor or, somebody had said, I took this class in school and, maybe we could consider that this might be the beginning of something serious. And if we can catch it sooner, here's a pamphlet, there's it just like, I remember, I've heard that there's brain damage every time you have a psychotic break. So I don't know where my son's recovery can be. I know when he was on Clozaril, he was doing really well, but I would say we got him back 65% and I'll take it. And it was enough because he was working and, now he is 10%. I don't know. I haven't seen him because I'm doing with his practitioner exactly. They keep saying he trusts us now, and that's where I'm leaving it. He doesn't even know I'm speaking to them because I need to be out of it. He needs to find that trust. But so that's very powerful to me, that like, see the signs, see if you can catch it before the psychosis. So what I'd like to do is just focus in the last few minutes on what would you like the system to do? What would you like to happen in the system? And that includes educating what would you like to vouch for so that more people can be caught and helped before they reach the stage where recovery might not be as possible? Bob, I'll go to you first.
Sure. On my website, with robertcsmithmd.com, on the very first page, there is a spot where it's called join in to, there's a sample letter that can be plugged into your own email. And then there's a link to email addresses of relevant people, including senators and Congress people, where you can find their email and then plug it into your own with the sample letter below. There's a space to even give your own experiences with it, but it is advocating that medical education be investigated for its lack of a scientific approach and failure to address mental health care. And it's only at this level with federal action and then direction that anything's going to happen. And here is a way you can have input directly to your representatives.
Love that. Thank you. Vinod. So we have roadmap and mind map. Okay.
I'll turn the question around. I am in the healthcare system in Connecticut, so I want to know from people in Connecticut, what should we be doing better? We are trying to collect data, and we're trying to publish an annual report every year on how many people we're getting into care, how fast. And our goal is to get everyone with a new onset schizophrenia spectrum disorder in Connecticut into good care fast. If you're asking what my wish list is, I would want more resources for research to help with better early identification. And some of this is happening at Yale, and we have a sister clinic that if you have us back, Randy, I can introduce you to my colleagues who are working on improving early detection before the first episode. And I think on the other side, better payment models that don't punish clinics for spending time coordinating services that are currently very hard to bill for, or spending time with family members, which again is something that's hard to bill for. So maybe those will be my two things.
Thank you. Mindy.
I wonder, Vinod, have you gotten involved in what Randy's gotten involved in, the push in Connecticut for AOT, which is one of the tools in the toolbox? It would be so much better to do what you two are saying, get in early, develop relationships, woo people in, don't argue about if they have schizophrenia or not, just get going on something. But in extreme circumstances, which my family has certainly been in, our son has been civilly committed 7 times and extensions because he had severe anosognosia. And now he doesn't, and he's doing really well. But have you gotten involved in that discussion? And if so, could you share what you think?
Yeah, no, I have been involved in discussions around that. I think we would want a society where when a person is clearly not able to make good decisions, we don't wait for them to actually hurt themselves or someone else or inadvertently commit a crime before we provide care. So I think we have to do better than the current approaches we use. I think when it comes to nudging people into care, whether it's some kind of outpatient commitment or AOT, I think those are good tools to have, and we just need to be very careful about how we implement them and make sure that as far as possible we use a shared decision-making approach. And when that's not possible, we're very careful about not inducing disparities that might occur quickly when people are being forced into care. So my answer is it needs to be done well. Maybe is the and I think we can do it in Connecticut. We just need to think through it and move ahead. Yeah.
Thank you.
Thank you.
What I keep coming back to in my mind is this division that's created by having one guy is in charge of from here up, and another doctor is in charge of from here down, and knowing so clearly it doesn't work that way. And again, the communication, what's ended up happening as Nick's life has unfolded is it was actually the doctor who delivered him who helped me when he started having a psychotic break, because I couldn't get to anybody else. And it was also a general practitioner when we moved to the country who helped me, because there were no psychiatrists. And it just seems to be that it's so splintered, and it's communication, because if we had been given as moms, if we had had the knowledge we have now back then, I would have handled things so differently. When they're 15, 16, 17, you don't have to worry about HIPAA. You don't have to worry about, but you're busy worrying about the rules of parenting, and you don't want to overstep this bound and overstep that bound. And if I had known that this is what I was dealing with, I wouldn't have cared about, what anybody thought. I would have done what I knew was best for my kid. And that, again, is the education, and the psychiatrist talking to the doctors, and the doctors listening to the parents. And it's this education of listening. And I look at it and I think that that's really where the solution lies.
And on that
That's not
note,
really a question, it's more of an opinion, but there you go.
that's a great opinion. Well, I share it.
So do I.
When Nick the doctors will appreciate this. When Nick was first sick and they told me he was first diagnosed with bipolar, first depression, then bipolar, and then eventually. So from 16 to 20 were all these diagnoses and all these different medications, and he didn't want to take them. And so I said to the doctor, I said, the only thing I can possibly think of is I could offer to pay him if he would take his meds. But that just seems like the worst thing in the world to do. And that doctor gave me good advice. He says, all bets are off. Everything that you think you know about parenting, put it aside. All that matters on the earth right now is you get this medication into this kid every day. And I remember sitting in the kitchen around the kitchen counter there with my younger daughters there, paying Nick $10 a day to take his medication. And these girls look at me like, well, nobody ever paid us to take our amoxicillin. What is going on here? And it was just like, but I knew because the doctor had given me permission. He had explained to me that it doesn't matter. Get the meds into him. And I mean, these are the things we need to know. These are the conversations and the communication that needs to happen. Not everybody running around walking on eggshells, afraid to do anything.
Thank you. Thank you for that.
I'll shut up now.
This has been a fantastic discussion, and I'm so glad we had you on together. Dr. Robert Smith, his book is Has Medicine Lost Its Mind? And the website, robertcsmith.com. Is that what you said?
Robert C. Smith, MD.
robertcsmithmd.com.
Too many Smiths otherwise.
And then mindmapct.org is the website, and you can just Google what did you say? They should Google psychosis CT early intervention. You'll find it. It's right there. Thank you so much for the work you're doing and the information you're spreading. And if you're listening and you're thinking of going into pastor work, social work, high school teacher, guidance counselor, take that elective in mental health. Take that elective because you may help a family. We're Three Moms in the Trenches. Thank you so much for joining us.
Thank you for having us.
Thank you so much for tuning into this episode of Schizophrenia, Three Moms in the Trenches. You can help out the podcast and help others by sharing the podcast and by subscribing wherever you get your podcasts and or on YouTube. And remember, you can reach us at mindygreiling.com, randyk.com, or miriam-feldman.com.